We want to go ahead and welcome everybody to today's Family Medicine Grand Rounds for February 23rd. If you are interested in CME credit, you will want to make sure that you text the code there. I'll put the information in the chat box here shortly. But that is today's activity code, and you'll want to make sure you text it to the toll-free number there before midnight tonight. But I'll put that information here in the chat in just a moment. Next slide. There are some instructions there as well. I know most of you are probably already familiar with that, so we'll just go ahead and go past that slide. And as we get started here, I just want to take a moment to remind everybody, if you haven't already, please make sure that your microphone is muted as we go ahead and begin. Also, if you could remain attentive and engaged in the session. Our speaker has asked for us to put the questions in the chat box, and then we can go ahead and we'll take a look at those towards the end of the session. But also in the chat box, I'll be putting the evaluation form. If you could help us, please provide feedback for our session and for the speaker, we'd really appreciate that. Next slide. So this is the South Texas Regional Family Medicine Grand Rounds, and we are partnered with the South Central Area AHEC. And our department's mission statement is there for you. Next slide. CME transcripts, you can view those at the CME office's website. It's listed there. And if you need that transcript, you just go to the My Transcript section there on their page. But if you're having any issues, please feel free to contact me, or you can contact them directly. Next slide. We do also offer AAFP credit for this session, and you would need that CME transcript to submit to the AAFP. But any questions or any concerns with that, please feel free to reach out to me or directly to the AAFP. We also want to make sure that we do mention that it is the goal of all of our FCM Grand Rounds sessions to address the following nationally established physician core competencies, as you see listed there. Next slide. And just want to make sure that you know also that Dr. Mansukhani has no financial relationships with ineligible companies to disclose. And so the topic for today's presentation is obstructive sleep apnea for the primary care provider. And we have Dr. Mansukhani here from the Mayo Clinic. She's a professor of family medicine and co-director for the Center of Sleep Medicine. So I will let her go ahead and get started.
Well, hopefully you can hear me okay, Nicole.
Sounds good.
All right. Well, thanks so much, Nicole, for all of your help with getting this arranged. And a big thank you to Dr. Fawzia Ali, who invited me initially. I have given talks at your facility before, but this time we're doing it through Zoom since we're in new pandemic times. So as Nicole said, I'm a family physician who practices sleep medicine at Mayo Clinic, and this was the topic that was requested by the folks who organized Grand Rounds. What I wanted to do is give a brief background that puts the rest of the talk into context about obstructive sleep apnea. In terms of diagnostic techniques, we'll talk about what is new, especially in the new world that we live in with the ongoing pandemic. We'll talk about CPAP, and mainly with regard to what's relevant for primary care when it comes to follow-up. And we'll talk about some new treatments that are out there, as well as the established treatments that we have. So as you know, sleep disordered breathing falls on a spectrum. There's snoring on one end, which is just a vibration of pharyngeal tissues, and we don't think that is associated with adverse outcomes, apart from being annoying to one's bed partner. And then there's apnea, which is a complete cessation of breathing for at least 10 seconds. And then in between, we have these other kinds of events. One is called a hypopnea, which is a partial reduction in airflow for at least 10 seconds with desaturation of at least 4% is how it's been traditionally defined. When you add these events together and divide by the number of hours of sleep, you get what's called the AHI. This is traditionally what we have used to define how severe someone's sleep apnea is. Now, there's another kind of an event where there is some reduction in effort of respiration, but there's no desaturation or no significant desaturation. There is an arousal from sleep. So these are what we call RERAs. And when you add these events to the AHI, you get what's called the RDI, or the Respiratory Disturbance Index. So for the purposes of defining severity, say 5 to 15 for the RDI is mild, 15 to 30 moderate, and more than 30 severe. The focus in most sleep studies is still the AHI, because that's what Medicare wants when they determine severity and make decisions regarding reimbursement for it. So most of us sleep doctors, the way that we decide whether we're going to treat someone or not, if someone has moderate or severe sleep apnea, AHI 15 or more, most of us will treat. Or if the patient has any degree of sleep apnea with symptoms. There's this entity called UARS, which is on the spectrum, like I was saying, of sleep apnea, where the RDI is normal, the AHI is normal, but the RDI is high and the patient is symptomatic. So just so you know about that category. What about the epidemiology? So this is from the original epidemiologic studies that came out of community-based population studies, where you see in blue, in men and women, snoring is a pretty common problem, very prevalent, but those with sleep apnea are less common, and those that are symptomatic are even fewer. The newer data suggests, well, they've divided it by age category, but the newer data suggests that at least if you take middle-aged populations, about 1 in 4 to 5 men will have sleep apnea, and about 1 in 10 women will have it in the US. It varies by country. The other thing to keep in mind is that certain populations, like those with cardiovascular disease, those who are older, so above 65, and those who are obese, the prevalence is much higher. So for example, in those who are above 65, it is 1 in 4. And for example, those with cardiovascular diseases, it's usually about 2 out of 3. And those who are obese, it may be as high as 40%. So varies depending on the subpopulation that you're looking at. So why do we care about it? Why do we need to consider treatment? And I think most of you know the mechanisms by which sleep apnea causes these adverse consequences. In the acute stage, it would be hypoxia and hypercapnia associated with more so hypoxemia. There's changes, intrathoracic pressure changes with breathing against those glottis that are happening and arousals from sleep. So as a result, there is sleep disruption. Sympathetic activation is thought to be a big mechanism. There's metabolic dysregulation, oxidative stress, inflammation, hypercoagulability, and endothelial dysfunction that are thought to result in the end consequences. Now, playing into all of this are also the risk factors that we know about, commonly associated with cardiovascular and outcomes such as male gender, obesity, and smoking. This is the original study that we usually quote when we talk about the adverse cardiovascular events. You can see in red the cumulative incidence of non-fatal. This is the first slide is non-fatal, and the second slide is fatal. I think I got it mixed up on the y-axis events. There is a new study, maybe you heard of it, called the SAVE trial that was published a couple of years ago that did not show any benefit with CPAP. Now, this was a different population. It was those who already had a CV event. And the main criticism of the study is that of the majority of the subjects who were recruited from China, the adherence was very low, not what we would consider adequate in the studies here. So that was about 3 hours. So there are many, many ways to screen for sleep apnea, many questionnaires that are available. For primary care physicians, I like this one because it doesn't involve whipping out a questionnaire. You can just do it in your head and saves time. 4 things on history and 4 things on exam that you need to think about. If there are any, then the patient is at high risk. So 4 things on history everybody knows: loud snoring, snort arousals, witnessed apnea, and sleepiness. On exam, you usually have the BMI and blood pressure already there in front of you. When you think of sleep apnea, 2 things. You're going to measure the neck and look in the throat, right? So neck circumference 17 or higher for men, 16 or higher for female is a risk factor, and a crowded oropharynx. So I've seen a lot of primary care physicians also using the stop bang, which is quite easy to complete. The Berlin questionnaire is longer, and like I said, there are many other screening tools available. At least the American Academy of Sleep Medicine considers this a quality measure to screen for sleep apnea in somebody who does have a high-risk condition and a BMI of 30 within the last year. So this slide shows us on the left, Friedman parallel position, class 1, 2, 3, and 4. 3 and 4 are considered high risk, where you either see nothing of the soft palate or you see partially, you can see the soft palate. Some people do the malam party, like anesthesia, where the tongue is protruded. Here the tongue is inside the mouth and the patient says, ah. This is, everybody knows about the tonsillar classification. Now, high-risk patients would be those who are obese with heart failure, AFib, nocturnal arrhythmias, resistant hypertension is a big one, pulmonary hypertension, diabetes, stroke, commercial vehicle drivers, pilots, those coming to your clinic for PAMIs, those with obvious upper airway issues. And then newer literature suggests those with dementia, those with certain kinds of epilepsy, chronic headaches, chronic wounds. We get referrals from ophthalmology for certain conditions, and then chronic kidney disease. So what is the role of oximetry? I get a lot of calls from primary care on this. Part of my practice is I'm embedded in the primary care clinics to provide curbsides and other sort of virtual consultations. And this depends a lot on where you practice as to how much the test is used. But if somebody has you have a high suspicion of sleep apnea, you might not gain much by doing an overnight screening oximetry, unless you're trying to convince the patient. Sometimes it's useful to show them the drops in oxygen to get further testing done, or access is an issue. You're working on 20 different things, including their depression and blood pressure, and you think, I think showing that the patient has severe sleep apnea, treating that is going to make some headway. I need to target that first. I can't get into my sleep lab for 3 months. Sometimes having the abnormal oxy helps with that. In general, though, it's most useful as a rule-out test in somebody at low risk. So why would you do it in a low-risk patient? Maybe because you don't have adequate history, they don't have a sleep partner, maybe they have some cardiovascular conditions where you're trying to rule sleep apnea out for that reason. The limitations are, of course, that you might miss milder degrees of sleep apnea, especially in someone who's thin, who's young. It might not be a good screening test. Some of you who practice in hospital or even in the clinic, it takes a little time for the interpretation to come back. And if you were trying to do this yourself, trying to see if this is something that needs an urgent consult, I like to remember the 60-30-15 rule. 60 is if the minimum saturation on the report is dropping down into the 60s, that probably needs a more urgent referral. If the ODI, which is the poor man's AHI, that's the number of fluctuations per hour, is 30 per hour, that's going to be in the severe range. if they're spending about 15 to 20% of the time below 90%, that means their baseline is low, suggesting hypoventilation of some sort, that might require a more urgent consult. Now, whether you proceed to a consult or whether you proceed directly to ordering a sleep study, that varies depending on where you practice. So what are the options for testing? So we said oximetry is only a screening test. Insurance companies need a diagnostic test, and so do we, to really gauge how bad the sleep apnea is. And type 1 is going to be a full in-lab study that's pictured on the left. And type 2 and 3, there are many, many types of home sleep apnea testing devices. One that we use here in our lab is called Embleta. That's an example on the right. Now, the volume of sleep tests, home sleep tests, has been steadily increasing since we started doing it. And it reached about 1/3 of our total tests in 2014. And now with the pandemic, it's become 50-50, 50% home tests and 50% in lab, which is, considering we're a tertiary or quaternary level center, it's still a lot of home sleep tests. Most of the home sleep test referrals come from primary care. So in a traditional polysomnogram, we're measuring at least 8 different physiologic parameters, from EOG to EEG to EMG, body position, snoring, oxygen saturation, end-tidal carbon dioxide, body position, like I said. So many parameters are being looked at. In home sleep apnea test is some combination of cardiorespiratory parameters. So with the pandemic, this WatchPat1 really took off. And I don't know if this is something you're doing there, but it's very, very commonly done all over the country now. And this involves wearing just a watch-like device for a night with a pulse ox. You can see, and there's a little piece on the chest that serves as a body position sensor and a snoring sensor. And this can be, used in conjunction with the patient's phone. You see the data remotely, so they really never need to actually come to the office, because we mail it out to them. And so this was really a seamless way of doing it, and it became very popular during the pandemic, and it has continued to be very popular. So this device called the WatchPat, PAT stands for Peripheral Arterial Tonometry. We said that sympathetic activation is thought to be a big mechanism by which sleep apnea exerts its effects. And you can see in green here with each of the breathing events how the PAT signal, peripheral arterial tonometry, measured from the finger, goes up, which is a measure of sympathetic activation. So it makes sense then that if somebody is on an alpha blocker, like prazosin, for example, if somebody has AFib or a pacemaker, then those would be the big contraindications. But otherwise, most other patients can go through this sort of test, which is a diagnostic test. So which are the patients that you would consider as candidates for a home sleep test? This would be somebody who has a high pretest probability of moderate to severe sleep apnea. So we said that oximetry was a rule-out test. This is a rule-in diagnostic test. And the contraindications would be anybody where you're thinking they have something else apart from sleep apnea. So narcolepsy or something like that, you obviously wouldn't do this. Or they've had a lot of difficulty with their previous OSA diagnosis and treatments, and that might not be the best candidate. Anybody you're suspecting severe hypoxemia, hypoventilation on top of sleep apnea, you're suspecting you're not suspecting OSA, you're suspecting CSA, central sleep apnea, because they have cardiac condition. So basically those with cardiac conditions, other respiratory conditions, neuromuscular, skeletal conditions, you might not order this test. So it's just straightforward, moderate to severe sleep apnea that you're suspecting. And obviously they should be able to proceed with the test at home. So there are many advantages to these home sleep tests, of course. It's a virtual lab. You're not limited by the number of beds in your lab. It increases access. You don't really need a technologist, at least for the WatchPad, we don't need one. It decreases the cost significantly. It's like 1/6 the cost of an in-lab study. And that might not be the case if they fail or it's negative and then you have to do an in-lab study, but for most patients. Those who can't get to the sleep lab because of transportation issues or illness, it's definitely more convenient than all the sensors on in the in-lab study. And all of the references that you see there have shown similar outcomes with both pathways. The traditional in-lab study with a CPAP titration versus just doing the home test and then prescribing an auto CPAP. So what are the disadvantages then? Traditionally, the home sleep tests are thought to underestimate severity. We're not in a lot of these tests measuring sleep, we're measuring the recording time, not the sleep time. So naturally, the number of events is then going to be lower compared to if you were just calculating it based on their sleep time. So you might see this terminology, REI, in a home sleep test, which is basically what we use as an AHI when we're writing the CPAP prescription. But now the WatchPad does make some inferences, whether, patient is in REM sleep, non-REM sleep, so it's still called an AHI. So bottom line is there's conflicting as to whether it underestimates or overestimates. It depends on the individual patient, but most home sleep tests tend to underestimate a little bit. There may be data loss. There's nobody to refix, to put the sensors if it falls off and whatnot. But again, with the watch, there's only, the watch piece and 2 other pieces. So it's not as high as even 25% for the data loss. If you're wanting to titrate CPAP, obviously you can't do that at home. The idea is you're going to prescribe an auto PAP afterwards. It may miss mild degrees of sleep apnea and of course central sleep apnea with some types of sleep studies like the WatchPad. And again, we said if you've committed to a home sleep test because you thought the patient had a high suspicion of sleep apnea and now you have a negative test, then you have to follow through with further testing. Traditionally, that would be an in-lab study, but in real life, do we just repeat the home sleep test? Sometimes we do that. And lastly, there are some chain of custody issues. So what does that mean? This would be, for example, in a commercial driver, you want to make sure that the test you've ordered, the patient you've ordered it on is the person actually doing the test. Sometimes there's no way of knowing that with the home test. All right, so then we move on to treatment. And sometimes, depending on where you practice, the sleep provider might actually be the one to start treatment, or it might be primary care. But sleep apnea is a chronic disease, and chronic disease management obviously requires partnership between primary care and sleep medicine. And identification and modification of risk factors, like with any other chronic disease, is very important. The biggest risk for obstructive sleep apnea, the biggest risk factor is weight. And so there's so many new treatments out there for weight loss, and we can offer options from dietitian to medication management to surgery. Smoking cessation is another thing. Avoidance of alcohol or other CNS depressants, opioids, benzodiazepines, polypharmacy. All of those things can affect the degree of sleep apnea and hypoxemia. And of course, sleep deprivation or insufficient sleep can also increase the severity. And then, of course, education about consequences if it's left untreated. As we said, sleepiness is a big thing. So dangers of drowsy driving or operating heavy machinery. And then the other consequences fall into these 3 buckets of metabolic consequences. such as worsening control of sugars and things. Cardiovascular, we talked about blood pressure, arrhythmias, heart failure. Neurocognitive, we talked about stroke, worsening depression. And of course, there's quality of life issues, disruption of the bed partner's sleep, and things like that. Now, there is a bidirectional relationship between obesity and OSA. So sometimes treating the OSA can make a difference when you're struggling with weight loss. There are studies looking at abdominal fat on CT scans that have shown a reduction post treatment with CPAP. But there is also a lot of literature showing that patients actually gain weight once their sleep apnea is treated, and there's some hypotheses for that. So literature is conflicting. Basically, we do advocate for treatment, but say that you also need to follow the general lifestyle measures of increasing physical activity and dietary changes to really result in weight loss. So in a mild case, that may be what is sufficient. We usually aim for 10% of weight loss before we recheck with another sleep study. We recheck after bariatric surgery has been done when they have reached their maximal weight loss, which is usually about a year out. The other form of treatment for mild sleep apnea might be positional therapy with the help of vibration devices or other mechanical devices to help the patient stay off their back if it is positional sleep apnea. And then the gold standard treatment is considered to be CPAP, which we all know has an initial acceptance rate only of 70%, and then compliance falls off by about 4% a year after that. So adherence is definitely an issue, but at least it is something that we can monitor with objective data, and it ends up being similar to compliance with medications, other medications, with a lot of chronic diseases that we encounter in our practice. So with CPAP, there are two types of devices. Fixed, you can prescribe a fixed pressure, or after a home sleep study would generally be an auto titrating device. Now, there are many other kinds of devices that are out there. And I just put these for informational purposes. The BiPAP, or another brand calls it VPAP, these are bi-level positive airway pressure devices that can be set in a spontaneous mode. It can be set in a spontaneous time mode, which means there is a backup respiratory rate in there, or automatic mode. The ASV, which is an automatic or adaptive servo ventilator, Medicare puts it under the BiPAP category, but it's different. It constantly monitors on a moving window the patient's respiration and gives you 90% of the target minute ventilation, or peak flow is how it works. But the thing for primary care to remember is that we basically use this for central sleep apnea if the patient's ejection fraction is greater than 45%. And there are these other devices, we call them AVAPs, you may have heard of, or IVAPs, which is a volume assured pressure support kind of device that we use for hypoventilation. So this would generally be used in patients with ALS, but sometimes obesity hypoventilation, or COPD and sleep apnea with hypoventilation. The other treatment options that we'll talk about today are oral appliances. For people who don't have teeth, the oral appliance is not going to work. So for edentulous patients, we use a tongue retaining device, which basically works on principle of suction. It's not very effective. I'll show you some pictures about Provent and Winx. Most of these have been phased out. Provent, the company shut down, but you might have some patients who are still using it. There's something new called Theravent, which is used for snoring, not so much sleep apnea. And then in terms of surgery, we'll talk about the new Inspire device. UPPP has fallen out of favor. It's less than 30% effective. There are some new palatal procedures that are being done, very limited data available, but suggests it's more effective than UPPP. Maxillomandibular surgery is very effective in the 85 to 90% success rate with that. But there are only a few centers that do it. And then, of course, bariatric surgery. And with bariatric surgery, about 1/3 of patients, they tend to lose their sleep apnea completely, but the others, they still have it. It tends to be milder. And then medications and oxygen really play a very limited role. So lots and lots of CPAP machines out there. The ones in the middle are the new models, as well as the one at the bottom. This is specifically made for women with the design. You can see, you may have heard of the new, the Philips recall that had caused a lot of havoc in our specialty. So basically the foam that is used in the machine to abate noise, particles of the foam as well as fumes were being released into the air that was being breathed in by the patient. Now, theoretically, that can cause irritation of the mucosal lining and is potentially carcinogenic. We don't know the actual risks, but like I said, those were the hypothetical risks. And patients, if they were eligible for a new device through insurance, were given that by the primary care physician, or somebody had to write the prescription so they could get a new device if eligible. Otherwise, depending on how severe their sleep apnea was, you had to make an individualized decision whether to continue with that machine or not. And they all have to register with Philips to get a replacement. And initially, the waiting period was over a year, but now it's come down to a few weeks to months. Similarly, there are lots and lots of different masks, or we call them interfaces, to deliver the air. These are some of the older ones, and these are some of the newer ones. So the one on the bottom left is being very commonly used. It just fits below the nostrils, and it's very light and sort of flimsy. There are some people who are obligatory mouth breathers, and we might use something that either covers the nose and mouth, or just the mouth, like this one, or a hybrid that goes into the nostrils and covers the mouth. There are ones that are just stuck behind the ears if people don't want their hair messed up. We can get chin straps for people to keep their mouth closed if they still want to use a nose piece. And so lots and lots of different options. Every month new options come out. There's close to 200 to 300 options that are available. Now, in terms of follow-up, every time they are seen, say for a general medical exam or other follow-ups for sleep apnea, these are the questions that we focus on. Number one, do they have any persistent symptoms of snoring or sleepiness? Are they having any problems with the treatment? So then you try to break it down as to, are they patient-related problems, or is it relating to the equipment? Is that need a replacement? Is there a big change in their weight or their comorbidities since the time of diagnosis? That might be a reason to retest. Often our primary care physician providers will, they may or may not look at a download that is sent in by the vendor. They might order an oximetry, which is quite useful actually to see what's going on if they're suspecting that the patient needs to go back to see the sleep medicine. Many of the problems that patients have relating to the CPAP can be fixed really by increasing the humidification on their machine. And really the vendor can do that. A lot of the problems also relate to mask fit. And, sometimes it takes trial and error to find something that works. And those need to be replaced quite frequently. So sometimes it's those simple things. Other times it's nasal congestion that still needs to be treated. And often we prescribe nasal sprays for those. So now patients can monitor their data on an app. This is, for example, the My Air app by ResMed, which is one of the companies that makes the devices. It gives them a score based on their usage, their mask fit, how many events they had. I mean, it's just a made up score, but it may be motivating for some people. Anyway, this is a sort of a night by night, this is a nightly screen that we're seeing here. So this is the report that we generate from the device, which can be done remotely, or the vendor can send it to you. So the vendor can send it to you remotely, that is, they can download it remotely and then fax it to you. The patient physically does not really need to take their machine in with the new ones. So in what I've highlighted is that basically the three things that you need to look at for ResMed. There are two manufacturers commonly for CPAPs. One is ResMed, one is Philips Respironics. So for ResMed, it's the first page that you look at. You see what the AHI is. Less than 5 is ideal. Yeah, of course, it depends where they started on their diagnostic study, but less than 5, so 3.5, that's good. And then down here, what's their daily usage? 7.5 hours, that's good. And then for Medicare reasons, we usually want to know what is the percentage of days they've used it more than 4 hours, 91%. Now, this is the Respironics one, a little more busy, the report. And it's usually the last page. So you get a stack of papers. You just quickly go through, just go quickly to the last page. Average usage, 7 hours. Percentage of days with use more than 400%. And the AHI here. So if you had to dictate something in your note, those were the things you wanted to, Medicare wants to know. Is the patient benefiting from treatment, and how many days are they using it more than 4 hours? The daily usage has to exceed 4 hours in the first 90 days for continued reimbursement. So these machines don't really tell us how they're calculating AHI. Those algorithms are proprietary, and just know that if you're seeing high AHI numbers, that could just mean the leak is high, or it could mean another reason. You might want to look at the apneas, how many apneas they're having, apnea index, which because the hypopnea is not very accurate. There are lots of other things. If you wanted to dig into, you can see what pressures it's delivering, what the humidity settings are, if there's a ramp on it initially, if there are other relief features that are set on it. So these are the olden day mouthpieces or oral appliances that we use. This is a more current version that's actually very small and light. It's made of a plastic-like material with a little metal piece on the side that you would titrate to pull the lower jaw forward. More and more dentists are giving patients that tool to advance it, and they tell them how much they need, how many rounds they need to do, how many turns. So this is not a bad option for mild to moderate sleep apnea. For all comers you take, then the success rate is 50% if you're looking for an AHI of less than 5. But if you're looking at a patient with mild to moderate sleep apnea, you're looking at, have they improved their AHI at least 50%, and it's reasonable, less to 10 to 15, say. Then the success rate climbs up to 75 to 80%, which is not bad. And the predictors of success, we still don't know. We need a lot more research on it, but it seems, at least based on some papers, that if the patient has more of a positional component or they're low BMI, it might be more successful. Head-to-head comparisons, there are quite a few studies with CPAP, And the AHI is comparable. We said it's better reduction with a CPAP, but it may be more tolerable. The oral appliance may be more tolerable in many patients. And ultimately outcomes in terms of sleepiness, in terms of blood pressure reduction are actually quite equivalent in a number of studies. So this is Provent. Like I said, the manufacturer has stopped making it, but it builds up pressure with exhalation and increases pressure in the back of the throat, which is how it works. And many patients used it as salvage treatment, but like I said, it's being phased out. Again, useful in mild cases. Wings works on suction in the mouth, again, not being used all that much, but you might see a few patients who are using it. Which brings us to the last treatment that we're going to discuss, which has been heavily advertised, at least here in Minnesota. This is called Inspire, or it's also called hypoglossal nerve stimulator or upper airway stimulator. So at the bottom, you see the patient is given a remote control device, and it's a daytime procedure done by ENT with a breathing sensor lead and a stimulation lead and the actual generator that's implanted under the chest. And the patient switches it on at night and switches it off in the morning. We do titrate that stimulator, or we do set this in for the settings to control sleep disordered breathing in the lab. And it may require more than one sleep study to do that. So I get a lot of questions about which patients would qualify for this treatment, because they ask their primary care physicians about it all the time when they're not able to tolerate CPAP, or they may not be candidates for an oral appliance. So this is something that is fairly new. It was only FDA approved in 2014. And it is approved only for those with moderate to severe sleep apnea, but not very severe. So anything under 65 per hour. They should not have a lot of central sleep apnea. And importantly, they need to have failed CPAP, meaning, so if they met Medicare criteria and they were using it, even though they hate their CPAP, unfortunately, that doesn't qualify. They should have failed it. They shouldn't have, been able to use it much at all. And another tough thing criterion to meet is that the BMI has to be under 33. ENT does a DICE, which is a drug-induced sedated endoscopy before, to make sure they're a candidate. Because if they have concentric collapse of the oropharynx, then they're not a candidate. Obviously, it's very expensive, and prior authorization is required. The most common side effect is discomfort in the tongue. We're seeing some headaches and facial pain also, but no serious side effects as such. And it seems to be effective at least for 2 years, if not longer. There are some 5-year studies showing that there are no long-term side effects. Some types of MRI are precluded if the patient has the stimulator implanted. And when you look at the original study, the New England Journal of Medicine study that came out on this particular device, the RCT, and you look at the supplemental data, even in those who were initially deemed candidates, in 1/3 it completely failed. And in the others, the reduction was about 2/3 in the AHI. AHI came down by about 2/3 from baseline. So in summary, we know that obstructive sleep apnea is a common problem. It is associated with adverse effects. It is easily recognized, and it is a treatable condition. However, there are significant issues associated with cost and with access to services we required. So we really need to know when to order the test and which patients with sleep apnea need treatment. So that's all I have for you. I'm happy to take Any questions? If people want to speak up, or if there are some in the chat, then I'll address those. Otherwise, you can always contact me by email about this or other topics. I practice all of sleep medicine, so new medications, insomnia, restless leg, whatever it might be. Happy to take any questions.
There is a question in the chat here. It says, how do you usually advise a patient on CPAP adherence?
How do you usually advise patient on CPAP adherence? So I'm trying to, I don't know if Yunshi, if you're here, but is your question about,
I'm here. I can talk.
yeah, hi.
Yeah, hi. So my question is, a lot of my patients, they are diagnosed with OSA, they're ordered CPAP. However, there's due to discomfort or the fitting of the mask, they just stop using. And it's very hard for me as a PCP to convince them to go back on it. And then just to see if you have some tips on how we
Sure.
can, as a PCP, to advise them to continue.
Yeah, and
using.
that is a big issue, isn't it? Is CPAP adherence. And so I think it goes back to that, trying to decipher what is the problem. If it's just that the equipment is too old or they need a different type of a mask, it's relating to some equipment failure, then you refer them to the vendor as a starting point. If it is relating more to, say, anxiety or claustrophobia with the treatment, then we do what's called desensitization for that. And you might have to refer them to the sleep center, where they usually have a nurse or a technician to help with that. If it's another patient-related issue, for example, there's significant dryness, or that, we talked about the humidification. If it's nasal congestion, that's the issue, then you prescribe the sprays. So it just depends on what the problem is. Sometimes it's insomnia that they actually presented with, and they ended up with sleep apnea as a diagnosis, and the focus completely moved to that, whereas actually they need CBTI to address the insomnia. So it just depends on the individual patient. I would make every effort to get to the root of why it is, so you know which way to proceed.
Thank you.
Any other questions?
Yeah, question about insurance. So a friend of mine who does sleep medicine was implying that a lot of insurances are trying to push more towards home testing because it's cheaper for them. Is that what you're finding?
Yes, exactly. So we're lucky where Blue Cross Blue Shield Minnesota has allowed in-lab or home sleep tests, but a lot of insurance companies, it's out of your hands. They will say, these are our criteria. Patient needs a home sleep test first. We're not going to pay for in-lab, whatever the case may be. These are our criteria. And usually it's the ones I pointed out. So, but they may be more restrictive. So like when I said cardiac conditions, for most companies, it is heart failure with NYHA class 3 or 4, something mild or AFib, it doesn't matter. Most cases, they will say BMI 40, or they may say 45, we will pay for an in-lab. The others would be neuromusculoskeletal conditions or certain respiratory conditions. If the patient doesn't meet any of those criteria, you have to order a home sleep study first. Then it depends on the sleep medicine provider to actually put in the interpretation. If it failed, for example, or it's complicated, they have to say, this patient's sleep study, home sleep study, showed sleep related hypoventilation. We advise formal in-lab titration, and at that point you still might get by, or you might end up with a peer-to-peer. So it just depends on where you practice. But in short, what you're saying is very, very true. In fact, overnight, many sleep labs closed on the East Coast because of this, that insurance companies were mandating a home sleep test only.
So to order the devices, usually you need the numbers that come from the titration. You had mentioned something about auto PAP.
Yes.
Does that have a range where you don't need
Yes.
a titration, or how does that work?
Exactly. So, in the olden days where we did the titration, that was easy. It said CPAP 7 successful. Okay, so you prescribe 7. But now after a home sleep test, what you would do is, so the range goes from 5 to 20, and there's really no evidence or even science behind this. Normally, if it's milder, you would say something like 5 to 10 or 5 to 15. Somebody with a BMI of 40, you might, say 10 to 20, but it doesn't matter. You can even just set the full range, 5 to 20, and you can always narrow it down later depending on what the patient is saying. They're saying the pressure is going too high, or they're saying they're hungry for air. You can adjust it, but 5 to 20 is what you could put on the prescription. So hope that makes sense. It's 5 to 20 centimeters of water. Now, in the olden days, we thought fixed CPAP was much better. I mean, it was more effective in that, but it turns out that when it comes to tolerability, when it comes to efficacy, they're the same in the studies, fixed versus auto titrating. The only one place I would caution you about is if a patient has significant baseline hypoxemia and you corrected it at a certain pressure in the sleep lab, then in converting to auto titrating PAP might be a little problematic because they might still be hypoxic at the lower settings. Apart from that situation, I think, or they have central sleep apnea. Apart from that, it's pretty equivalent. So if home sleep test, which would be a straightforward OSA patient, you would prescribe auto CPAP and you could do 5 to 20.
Ice cold.
All right. Any other that was a great question. Any other questions?
Yeah, it would seem like, we just give them a number and it's dialed into the machine. Is there any, I've never heard of the patients dialing the different numbers. Has that been worked on, and has that had any success?
Yeah, so actually the patients are not supposed to, they cannot alter the prescription settings. They can alter other things, like we mentioned, they can talk with the vendor about changing humidity settings and other things. But they're not supposed to alter that pressure setting that you set on there, like 5 to 20, say. Now, do they go on YouTube and mess around with the settings? They sure do, especially if they're engineers. I'll say they'll go and do all those things. But on the app or on the machine, they're not supposed to really alter that.
Why is that? What's the danger with that?
Yeah, sorry?
What's the downside of that? Why isn't that?
Yeah, that's a great question, because so there's so many things, right? If you got an optimal pressure setting that you said, like we said, 7, because they were hypoxic at 5 and 6, they shouldn't really be changing it. If you go higher, if they have central sleep apnea and you go higher on the pressure, that might worsen the central sleep apnea. Lastly, if they have bad heart failure and they're blasting themselves with a high pressure, that can decrease preload. So again, in general, there's not a lot of downsides, but theoretically there can be these risks. So that is a prescription thing that is set by the provider as the therapeutic setting, and they are not supposed to really change it. Now, these machine manufacturers, they have created algorithms where you have prescribed 5 to 20, and the algorithm in the machine will say that actually most of the time 90% pressure the patient is getting is 10, and 2 weeks later the machine converts to 10. Again, they're not supposed to engage that without your permission, but sometimes that does happen. Any other questions?
Yeah, sometimes we see the sleep study results with low AHI but high arousal index.
Yes.
Do you think it has, lot of cardiovascular effects or in the kidneys, and you treat it more aggressively, even the AHI is high?
That's a great question.
And
So,
it's very hard to treat by the auto PAP, so the patient need to go to the lab for titration for the RDI.
That's a great question. So that's where we talked about this upper airway resistance syndrome variant, where the AHI is low, but the RDI is high. So in this patient, they're obviously not desaturating much, but they're having a lot of arousals. It might be, say, a young female patient, where traditionally we've thought 4% is too much to require for a young female patient. And maybe even with lower degrees of desaturation, they're actually at the same cardiovascular risk. So that is still a big debate in our field. But the short answer to your question is that the vast majority of well-done RCTs have shown that that AHI number with a 4% desat criteria is what is associated with cardiovascular events and not the RDI. So that is why Medicare refuses to pay for treatment for pure elevation in RDI without an elevation in AHI. As sleep doctors, we think they're along the same spectrum, really. And so if somebody is sleepy, they merit treatment. So that's where the debate comes in. Now, with just an arousal index being elevated, that could be so many things. It could be a poor night of sleep in the lab. It could be coming from their periodic limb movements. Are those things bad in the long term because they cause sympathetic activation and disruption to sleep? Sure, they could be. It's just that we don't have the hard data to support it, to support treatment. Hope that makes sense.
Sometime in the report, we can see the arousal index is due to the snoring,
Yes.
respiratory events. So in that case, I think we can justify treating
Yes,
patients,
exactly.
especially with the for the patient with the heart failure or renal
Yes.
failure.
Yes, exactly. So you can use that. The other thing is it's only Medicare that requires that 4%. Actually, the current scoring criteria is if it's 3% or arousal, that actually counts as a hypopnea. So if it's a non-Medicare patient, you can always have your sleep lab rescore the study. If your AHI is less than 5 and you're fighting insurance, if you think you're going to fight insurance, you can always have them, you can say, this is a young patient, not a Medicare patient, and I feel they are having a lot of events. I saw the RDI is elevated. Can you rescore the study using the new criteria? That's always an option. But to keep it simple, like you said, the HI is slightly high, the RDI is very high, the patient has other reasons for treatment. Yeah, go for it.
Thank you.
Any other questions? All right, well, thank you once again for inviting me, and thanks, Nicole, for all your help. Thanks for the great questions. Again, if there's anything that you didn't have answered today, just feel free to email me.
Thank you so much for presenting to us today, and thank you for everybody joining us today, and hope you have a great day. Thank you.
Thank you. Bye-bye.